I hope you all can see my slides. It's always a privilege to review some interesting articles with the likes of my dear friends Dilip and Raghu, and now we have Praneeth, and we are kind of missing Sarita. So what we've done this time is, fortunately or unfortunately, this is what I was asked to present at the CSI. For those who have attended the CSI and have were in the hall when I was presenting this, then maybe it's a recap. But the best way to welcome a new year is to pay obeisance and ode to the previous year. And all the learnings which have been practice changing from the previous year is what we intend to cover in this trial parade. Now, before we start, I mean, it's very evident that our first trial, which we are going to be discussing, is going to be related to cardiogenic shock. We all know that STEMI, 1 in 10 STEMI will develop cardiogenic shock, and only about 50% will survive. And this cardiogenic shock has been the Achilles heel of interventional cardiology all over the world, regardless of the clinical profile. And we all have been through a lot of mechanical circulatory devices. We've been through the fact that whether we would like to do mechanical support first or open the artery first. We've been through all of that. And yet we don't appear to have come to very logical conclusions for evident reasons. The most important mechanical circulatory support could only add 0.5 to the cardiac output, which is actually when the IBP shock 2 came. So if we just review this, we had great expectations, because we also know that cardiogenic shock can be multifactorial. It can have a component of cardiac arrest. It can be LV failure. It can be RV failure. And we actually put to test the microaxial flow pump, which we all popularly call the impeller, in this trial, which is called the danger shock. So I think the danger shock was kind of a game-changing study, because although the number of patients that were being randomized were only about 360, out of which only 355 were included in the final analysis, between about 179 in the Impella group and 176 in the standard care group. But why this is important is because this could have important ramifications to allow us to use this device to save lives. And to save lives, we all know this device comes at a specific cost. And therefore, at that cost, at that price point, we must be doing benefit so that the insurers and the payers also pay for this device. See, unfortunately, modern healthcare is capital expensive. So we start with danger shock, 355 patients, median age of 67 years, 80% male. They were sick because median lactate was 4.5. 72% had LAD or left main as culprit. 72% also had multivessel disease. Median 4 hours from onset of STEMI to randomization. 84% randomized in cath lab. Median ejection fraction 25%. Median systolic blood pressure 82%. And in SCAI classification, 55% was SCAI C and 45% was SCAI D or E. And these inclusion criteria we knew had to have STEMI, hypotension, as well as demonstrated hypoperfusion. That is why the lactate was important. Demonstrated LV dysfunction, most of them had less than 25%, and randomization when shock was diagnosed. We, of course, excluded in this trial, I'm saying we, but the people who did this trial excluded those who were comatose with out-of-hospital cardiac arrest. They also excluded a VSR or any other mechanical complication, and excluded those who had predominant RV failure. Because to say that you exclude all RV failure would be a misnomer, as there is most cardiogenic shock has a biventricular heart failure. The trial objective was simple: to determine whether the Impella CP improves survival in STEMI complicated by cardiogenic shock. when the shock is diagnosed, and the Impella CP could be placed pre, during, or up to 12 hours post PCI. And this was compared with standard care which was being given. Now, the findings were that the routine Impella CP reduced 180 days all-cause mortality due to STEMI. And this independent investigator-initiated study represents a landmark, as actually it is the first randomized controlled trial in acute MI cardiogenic shock to achieve its primary endpoint, and it is the first randomized controlled trial to in MCS device trial history to demonstrate a survival benefit. Now, we know that this has been published in a variety of different journals, and it can reduce death. There was less need for vasopressors. There was faster lactate clearance, and but it came at a price. It came at a price of increased device-related bleeding, acute kidney injury, and limb ischemia. So these are my key takeaways, that in contrast to the other mechanical circulatory support devices, the Impella in acute MI cardiogenic shock has a 13% decrease in mortality at 6 months. So with that, I open this for discussion to our great peer group. Maybe we can start with Raghu. I would like to know your comments on this trial.
Yeah, thank you, Dr. Anil, for this crisp presentation of the danger. Now, I had two things which are in my mind. The practicability of this device for our patient population, you tried to touch upon that in the beginning, although in a surreptitious way. Then the second thing is, why did the trial, because from a Dan to danger, why did it happen?
All right. Hello.
Hello. Yeah, go ahead,
Yeah.
Dr. Anil. Yeah.
So Dilip, a very interesting point, from Dan to danger. Why did it happen? So Dilip, I'd like to hear your comments on this.
Yeah, I think these are kind of first trial. We showed some kind of primary endpoints, met the primary endpoints, and at least we have some evidence in form of randomized control trial that MCS work in cardiogenic shock. And but it has given us a lot of ifs and buts. So the trial was completed over 11 years. So it took 11 years to complete the trial. They screened more than 1,000 patients, and then finally they selected 350 patients, odd patients, and NNT for harm was 6, NNT for benefit was 8. It was only the total death which was in favor, but besides that, there are so many things, so many gaps were there. But seeing at the face value of this trial, we got a trial where if we remove the kind of harmful effects of peripheral vascular harmful effects of bleeding or vascular complications, the cardiovascular endpoints were really favorable. And these patients were very sick patients, C, D, and D. So SKY class stage A and B, if we include, then the trials can become much positive. So it gives us 2 or 3 real points to ponder upon. Even if it was these were C and D patients, there was some benefit, hint of the benefit, and with growing kind of experience. This 11 years old trial. So the experience of large bore access 10 years back and now is different. So when we compile the information and the experience and the kind of positivity and negativity and the limitations of the trial, I feel it's essentially a positive trial, because with the experience, complications are coming down and cardiovascular benefit. This is my take for this trial.
Superb. I think you've summarized it very, very aptly. We have issues, 11 years for recruitment, and there is no reason why. I mean, it's very understandable why they took so much of time to get the ideal patient for inclusion, to remove those who wanted to exclude, because you want a cohort which can be comparable. It's no point comparing apples to oranges. You need to compare apples to apples. And to demonstrate a benefit was largely a requirement in some of the insurance payer-led market economies, wherein they needed an establishment, not just a conceptual hope. They needed trial data to support that use of this device, which does not come free of cost, which does not come without the risks of peripheral vascular complications, will still benefit a substantial majority. And we all know that because of the heterogeneity of the cohort, even previous trials like the IBP trial has actually failed at the box office, you can say. But here we have a trial which has kind of succeeded. It has allowed many countries to include this in their reimbursement guidelines. And therefore, I think it is a way forward. And truly, what Dilip mentioned very, very correctly is the fact that our growing experience with large bore access, the comfort which I recollect a few years ago when we would take a large bore access, you would need to have somebody supporting the large bore access. But today there are fellows who are taking large bore access, and that is one of the real growths which has come, because you cannot have too much of delay in providing MCS support. Because if you have too much of delay, then you probably have already lost the battle, because the spiral has set in. As somebody put an analogy, the house is already burnt down, almost like the LA fires. So, Pranit, any of your comments on this trial?
Sir, I think the subset itself is very sick, and doing trials in this subset of patients is difficult. So, firstly, congratulations to the authors for their persistence to recruit these patients over the last 10 years. So, I agree with the comments by the previous speaker, Dr. Dilip, that it is very difficult to conduct trials in such sick patients. But we always feel very disappointed to lose these patients, and there is a definite burning need to do something about this. And this trial comes as a ray of hope that by using this flow pump, we are actually making them alive, because we are already losing this battle. So definitely a ray of hope that it definitely improves mortality. Now it's a learning point that these side effects which are kind of bothering us, be it acute kidney injury, bleeding complication, and the vascular complications, as you rightly pointed out, with increased experience and probably with also with the improvements in the design, we can get a devices which larger sheet size. Probably we also understand how to reduce these complications and the other smaller battles. I think we will eventually win over time. So I think this will be the first step in helping these six subset of patients, and over a period of time, both with the company modifying the device and we increasing our experience in handling large bore access, I believe we can go along forward in treating this six subset of patients.
Yeah, but the point which was raised by Dr. Raghu was very appropriate, that, when you need this device, it is seldom available as an off-the-shelf device. So my wish list would be that I have devised something like a balloon pump, which can be used when I need it, not having to go through a significant amount of planning or get payer approvals. And unfortunately, because a large amount of population in India still pays out of pocket, it becomes very difficult to muster the kind of financial resources to be able to initiate these therapies. So I think there are many new devices which we are looking at. We have the Magenta device, which is already had a presentation recently, and there are other devices by which we are going to improve, and with smaller access size. So I think it's a great first step, and I think that we are headed in the right direction, although there are caveats for our population, which is, so imagine our panel-driven patients. Where is it going to be applicable for them? Where all can you have the consoles? Where all can you provide the support when you need it? How can you be judicious about it? These are really, really, really very vexing and practical considerations. Does that, would you like to? I'm sure Raghu wants to add something to that. So I'm going to back to Raghu.
Yeah. Last point, Dr. Anil and Dr. Dilip. Overall, the results of the clinical trial looks to be good. the most important thing, who is the right patient to take up for these devices, is something which we still do not have an answer. There are a lot of gender differences between in the same study, where men had a difference which had completely driven the result towards that, and women had a increased mortality. We need to understand that these patients, when they had put these devices at women, they had more of vascular events, because women in India are much more smaller, and they tended to have more of renal dysfunction. So Dr. Dilip had brought out one very important point, NNT versus NNH, which is very close. And finally, what we need to understand is the p-value for the difference was also not very strong. Having said that, this is something which we all should look forward. And then there is one trial which showed a benefit in cardiogenic shock, which we badly require. And I hope we had a device which we can use off the shelf. Yes,
So
routinely. I think
really,
that's where
I
the
mean,
challenge happens.
despite the IIBP shock too, I still feel that a balloon pump is still a useful device at times when it went, because the issue, as Dr. Raghu said, is it too soon, is it too early, or is it too late? And that appropriate timing is still because of not just physician judgment, but it has also got many logistic, practical reasons which modify the actual decision making. So I think we all understand this. It's a step in the right direction, because once we have got approvals now, and many payers, many people, especially the CMS reimbursement in the US is very important. The Chinese have started reimbursing it. The Japanese have been reimbursing it. So unlike, say, oncology, where everything works only on hope, in cardiovascular practice, especially in the interventional cardiovascular practice, we think we need to be more objective and demonstrate not just efficacy, but also safety and also a cost benefit analysis advantage. So I think it's a step in the right direction, and let's hope we get more trials with smaller bore access, which are more convenient, which are plug and play, don't need so much of logistic consideration, and which cost less, so that we are not inhibited from using it.
Yeah, thank you. Thank you, Dr.
So let's move on. So a very, very important trial, and one of the burning questions in cardiovascular practice always has been identifying the vulnerable plaque. And we moved from identification of vulnerable plaque to identifying appropriate physiology. Then we moved from there to imaging. Then we moved to identifying the vulnerable patient. And then we also realized with the erosion studies, we also realized that we never, even in a STEMI, which actually did occlude, we could not clear the vessel adequately of the thrombus so as to be able to get a good picture. So, in the sense that two ways of dealing with vulnerable plaque, one was to make sure that we prevented the occurrence of an illness, and the second was of a STEMI, and the second was to make sure that once you have identified a patient who's got a STEMI, to be actually be able to look in whether this can be handled even without putting a metal scaffold. So we've had a lot of different trials. So we've had the prospect absorb, the vulnerable, the combined intervene, which is still going on. And what we are going to discuss, the interclima, which is still going on, and the favor 5 AMI, which is again in progress. And these are with intermediate lesions. Some of these are with image identified FFR negative vulnerable plaques. And one such trial, which was presented this year, which through Cat Among the Pigeons, and really I enjoyed seeing very tongue-in-cheek remarks by Jagat Narula on one of our WhatsApp groups, where he said this trial should never be done and it should never be discussed. I think to be that provocative is important, because even if something is disruptive as a concept, we need to get inferences out of it. Now, very importantly, the PREVENT study is important, because should we be looking and treating vulnerable plaques? Here is a 66-year-old diabetic woman with atypical angina, treated with aspirin and atorvastatin. You do an FFR 0.88, 3 months later, and it's happened to all of us. So can we prevent this? And the conceptual framework is to see, can we identify which of these was high risk, whether there was a thin cap fibroatheroma, whether there was a lipid rich necrotic core, which one would be fine by just doing a PCI with guideline directed medical treatment, or doing just guideline directed medical treatment, because then you are not giving a neo cap and you're kind of utilizing whatever you're allowing the plaque to heal. And can we use some of the new things like lipid scans to identify by near infrared thermography to identify the high risk plaques? So the PREVENT trial, which was in concept a preventive PCI versus medical therapy alone trial. And Songjin Park led this trial from Asan in Korea. And this trial was actually meant to be done with the bioabsorbable vascular scaffold. But unfortunately for the trialists, by the time this got underway, Abbott kind of withdrew the absorbed stent. So, well, you can say that they should not have continued with a metal scaffold because we understand the dangers of a medical scaffold. Or somebody can go right ahead and say that we could have gone ahead and put this to test with, say, a more important a biological treatment like a drug-coated balloon. But they went ahead and did a multi-center open-label randomized controlled trial, 15 research hospitals, 4 countries, South Korea, Japan, Taiwan, New Zealand, 18 years or older, non-flow limiting, FFR more than 0.8, vulnerable coronary plaques identified by intracoronary imaging to either preventive PCI plus OMT or OMT, and followed up continuous annually till the last enrolled patient reached 2 years after randomization. Now, during the course of the study, the primary endpoint was expanded to include rehospitalization for unstable or progressive angina. The virtual histology IVUS was replaced by Lipiscan or OCT, and BVS was replaced by a Zion stent or an everolimus eluting stent. So you can say the goalposts have shifted. You have Cristiano Ronaldo or Lionel Messi taking a shot, but the goalposts are not where they were supposed to be. But nevertheless, they continued. How did they identify the vulnerable plaques? Well, we are not really sure whether this is a perfect identification, but they use coronary stenosis more than 50% with negative FFR, where the FFR was more than 0.8, which met 2 of these imaging defined vulnerable plaque criteria. And this is based on Prati's work, with an MLA less than 4, a plaque burden more than 70%, TICFA, which is defined by OCT or by RFIVUS, and or a demonstration of a lipid-rich plaque by Lipiscan, where the LCBI was more than 315. Now, this was subjected, 800 people had just optimal medical treatment, because remember, it doesn't look like a critical plaque, and 800 had a preventive angioplasty as well as optimal medical treatment. They were not denied or deprived optimal medical treatment. Now, the primary endpoint was a target vessel failure at 2 years, composite of death from cardiac causes, target vessel MI, ischemia-driven revascularization due to unstable or progressive angina. And from previous studies, it was assumed that the incidence of primary endpoint at 2 years would be 12% for the OMT group and 8.5% for the preventive group, which corresponds to a 30% relative risk reduction. So therefore, a sample size of 1,600 patients provided an 80% power at a two-sided significance level of 5%, assuming a 7% loss to follow-up and crossover. So what are the findings? The preventive PCI reduced, lo and behold, the composite risk of death from cardiac causes, target vessel MI, ischemia-driven TVR, or hospitalization for unstable or progressive angina at 2 years. It also reduced the composite patient-oriented outcome or of risk or all-cause death, any MI, or any repeat revascularization. And the benefit was sustained throughout the 7-year follow-up period. Now, this is where we can see the curves. They have diverged right in the beginning, and there is a significant divergence between preventive PCI and OMT alone. So preventive PCI appears to benefit and so in both the in we understand that there is a benefit which we are seeing. Now, this patients were all given high dose statins or moderate dose statins plus ezetimibe in about 70% at discharge, 60% at 2 years, and at maximum follow-up. And the mean LDL was 64% in both groups, but less than 2% were on a PCSK9 inhibitor or a small interfering RNA. In conclusion, patients with non-flow limiting vulnerable coronary plaque, imaging guided preventive PCI reduced MACE arising from high risk vulnerable plaque compared with optimal medical therapy alone. And given the fact that it was the first large trial to show the potential effect of focal treatment for vulnerable plaques, these findings support consideration to expand indications for PCI to include non-flow limiting high risk vulnerable plaque. Now, for the purists, this can be quite challenging to accept. Like I said, Jagat Narula actually said this trial is an abomination, should never have been done, should never be discussed, because that way you can have tomorrow, you can give license to people to take patients who have even atypical chest pains and you can demonstrate some imaging criteria to show that this is vulnerable, to do unnecessary metal scaffolding in these coronaries. So the key takeaway has been that in focal non-FFR positive plaques, which are angiographically more than 50% and evidence of vulnerability on imaging, PCI plus OMT is superior to OMT for clinical outcomes at 2 years. So with this, this controversial, disruptive, should never have been done paper is now open for discussion. And may I start this time with Dilip? What are your views on this? Do you think you have encountered this in your clinical practice? Do you think you would like to implement it? How meticulous are you going to be with imaging documentation? How important do you think this trial is going to be? Should it have been done with drug-coated balloons? Should it have been done only with an absorbable vascular scaffold? Maybe we could have waited for a thinner strut when it came. These are the questions in my mind. I throw it open to Dilip for his comments.
So you had a lot of questions, but I have only one take on this trial. So I have noted this trial, got the idea about the result, what they have shown us, but I still would like to wait and watch, because we are progressing in two ways. One, we are changing our goalpost in LDL level. We are going to 10 to 15, and then that also, stabilizes the plaque. So I will not do any actionable feeling or thinking in my mind considering this trial. I totally agree with Dr. Jagat Narula's ideas. Yeah.
So you are convinced that this is an aberration. It could we should, because we are actually trying to treat a potential mechanical problem with a mechanical solution, but it is actually an inherently systemic biological problem, and we should be spending more time in addressing our efforts in trying to get a systemic biological solution rather than wasting our time at these focal disruptions.
Yes.
Is that how I could summarize your viewpoint, Dilip?
Absolutely, sir.
Great. What about Praneeth? What do you have to say on this?
So definitely disruptive. It challenges your thought process and the way you practice. Uh, as I said, it's like we are trying to play God. We are trying to predict future, that this is going to create an issue, and we are trying to prevent a future CV event. But we are trying to replace one disease with another by putting in a stent. Probably one attractive way would have been if we were stuck to only using a biovascular scaffold, because that can degenerate over a period of time and you are leaving a normal vessel, so-called normal vessel. But leaving a metal scaffold definitely leaves a bad taste. I would definitely do not want to treat one disease with another. But your other point on drug-coated balloon is also looks attractive, but we all know the limitations of drug-coated balloon in terms of dissections, probably flow limiting, or maybe recoil and others, which also may not serve the purpose of creating issue. You may
That
again,
coated balloons may not work here.
yes,
Because
yes,
if you don't
exactly.
create a dissection, you're probably not going to get enough drug into where you want
Correct.
it.
Correct.
So,
And that probable dissection might lead to flow interruption in a normally flowing vessel. So you are probably doing more harm than actually helping it. So I think the concept looks good in terms of preventing a future ACS event, but I think we are probably searching in a different way, because we all understand, if we look at the subclinical atherosclerotic trials, that by using intense lipid lowering therapy, most of these high risk vulnerable plaques do eventually heal and may not actually produce any CV event. I think you are absolutely right that we should be focusing more on the systemic factors and reducing the inflammation and allowing these high risk vulnerable plaques to heal and prevent a CV event rather than fixing it with a mechanical solution.
so I'm sure Raghu is going to say something very, very interesting on the PREVENT trial. Over to you, Raghu. Dr. Raghu?
You need to unmute yourself, Dr. Raghu.
Yeah, sorry. Yeah, Dr. Anil, my take would be like, this is a trial which has been done in patients with chronic coronary syndrome. Let us say these patients had angina. It's a chronic coronary syndrome. Still, honestly, all of us, when we take up any CCS patient, nowadays we will not jump to do a PCI for these patients. So that is why it would be we are four of us panelists here, despite a 90% reduction of events with a preventive stenting. We do not want to take up the baton, which is very surprising in medicine, because in medicine, if a intervention shows 90% reduction of events, which is very, very difficult in current day scenario, we still are limited. That's number one. Number two is, as you have rightly pointed out, the biological and physiological markers, like the troponin, and we do PCI based upon troponin, FFR, and all that. So that data is not there. Finally, I wanted to add one point, Dr. Anil, is we are all harping that BVS versus stents. And in this study, they had used BVS for some time and then gone on to the stents. The group which received the BVS did not have a long duration durability of the result. The stents had a much more durability compared to the BVS group of these patients. So I think BVS still has to go a long way to be used in our day-to-day practice. That's why, even though it showed a very encouraging results, but still all of us don't want to use it for our patients, because we are focusing upon the patient-centered results outcomes. Thank you.
So a very attractive concept. And I'm going to just take 2 minutes to say something even more disruptive, with the permission of my co-host. And that is, do we actually know the natural history of atherosclerosis? Do we know the natural history of a vulnerable plaque? Are we not just learning? Are we not, in electrophysiology terms, burning while we are learning? We've been practicing interventions, we've been putting stents in many coronaries. We don't even realize the natural history of what we are dealing with. We even the last time we reviewed a very interesting paper which was talking about the evolution of calcific nodules. It was a very small paper, but I thought it was brilliant because it came up with a new concept. And today I'm going to share with you that if you look at the advances in CT technology, we all know that CT also has 4 clinical subsets by which it identifies vulnerable plaque: the ring sign, and positive remodeling. And despite all this, we had the Scott Hart trial. And I think that a lot of our interventional learnings should come from the Scott Hart trial. Because we keep talking about LDL as being the cause. Yes, it permeates and it goes in, it gets trapped. I read a very interesting paper just 2 days ago as to how the LDL has the right size, LDL molecule has the right size to get trapped and then release, inflammatory cytokines, so that atherosclerosis happens. But the Scott Hart people tried to look at the perivascular fat index, and they actually got a brilliant new AI modality based software called the Carry Heart. And I actually wanted to do a trial on this, but I could not muster the funds. So this Carey Hart identifies patients who have an abnormal perivascular fat index, because we, even if the LDL is systemically elevated, we get focal disease in a large number of cases. We can discuss rheological factors, we can discuss branch points, we can discuss many other things, but the actual honest answer is we do not know. And some of the new things we are going to learn are going to come with the new photon counting CT. When it is going to be applicable, some of those, and when it is widely available, we know that right now it is almost 8 to 10 times the cost of a normal, say, 256 slice CT scanner. But once it is available, we probably be able to map the natural history of atherosclerosis. Maybe it's a heterogeneous entity. It may not be a homogeneous entity that one size fits all. So I'm just saying this that everybody should keep in mind, because we keep talking about CT and the power of zero, that if somebody's got zero calcium score and no plaque burden, he is not going to benefit. So I think per se, to my concept, the vulnerable plaque itself is very difficult to define as of now. So in fact, rather than calling it a vulnerable plaque trial, they should have said, defined as they have done, that only in these 4 characteristics will we do a trial. They've got some benefit. The cohort size is not very large. I think this kind of thing, because it has a potential for being abused. It has a potential where people might say, okay, give me a guide catheter, give me a wire, and give me multiple stents, and I'll stent everything from left main till the end of kingdom. So this kind of thing should be. We all know what that leads us to. So I think we need to be more rational. So I also concur with Jagat Narula's statement that this kind of trial probably should never have been done. I think we should spend more money, energy, time, and effort to identify the natural history of atherosclerosis and to identify what exactly defines a vulnerable plaque. Any comments, anybody?
I think we summarized everything about this, Dr. Anil. We'll go on to the next one.
Yeah. All right. So there are many unanswered questions. How do we use non-invasive? We've covered. How do we use invasive? What are the various technologies? So we know the high-risk imaging features which predict in the combined. We are going to actually just do TICFAS. And what is the best strategy? We also know that there was cryotherapy, the next generation BRS, and we know that there are future agents which are going to be doing the round. So from here we move to a very interesting and what is called the forgotten valve. And the forgotten valve and the forgotten valve disease was tricuspid regurgitation. And until now, we all had either recourse to cable repair by something which did not do very well, except that it would stop the backlash of the torrential TR on the systemic deterioration in spiral. So that was by using the trick valve. And we all know that that even surgical tricuspid valve replacement had many issues. That's why surgeons, by and large, tried to repair the tricuspid valve, largely unsuccessfully in many occasions, and did not, because of the low flow situation, did not even venture to put in a prosthetic valve. But now we have some data which has emerged for percutaneous edge-to-edge repair for tricuspid regurgitation. And here we are discussing the 3-year outcome from the TriLuminate data. And I'm going to go through this faster because by 3 years, 48 patients, of whom 80% had achieved a reduction of moderate to less TR. And we all know the challenges with the tricuspid valve. So a question which we ask our fellows is, how many leaflets does a tricuspid valve have? And that sounds like, how long did the 100 Years' War last? So it appears that everybody should say 100 years for 100 Years' War, and everybody should say 3 leaflets for tricuspid, but it can be anywhere between 2 and 7. So majority, and we know it's difficult to image, majority had a decrease of at least 1 grade. TR severity held steady between 1 and 3 years. But the good news was that heart failure hospitalization went down by 86%, and 84% more patients are more likely to have better outcome by using this. There was, of course, you can apply the Kansas City questionnaire by TR reduction, and that was superior. And hospitalization for heart failure, freedom from mortality, and tricuspid valve surgery improved. So the TriLuminate pivotal trial showed that tricuspid valve edge-to-edge repair was effective and improved the quality of life. So I think that this is a trial which we need to figure out, because in India, by and large, we have been, if at all, we have been doing is using a trick valve. A few cases where we have done edge-to-edge repairs, and a few cases where we've even thought of doing a prosthetic valve. So I would like to start with Dilip. What are your views on the triluminate?
I think this is a very kind of tricuspid valve is a ignored valve, which you just also highlighted, and this trial trial was a kind of a positive trial for that. But there are one or two caveats. They did not show any benefit in heart failure hospitalization rate. They had only quality of life which was better. The KCCQ scoring was better. There was no difference in mortality. There was no different heart failure hospitalization, and when to go after this tricuspid valve therapy is important. When the patient is totally potential TR, the patient who had a CIEDs with a device lead related TR which has progressed to severe to potential TR, when you are intervening is very important. And the basic bottom line for tricuspid valve intervention is when a surgeon has taken a patient for mitral valve surgery, aortic valve surgery, ischemic heart disease, better to fix the tricuspid valve if the leak is mild to moderate even at tricuspid level. This is the best way to treat tricuspid and take on the tricuspid valve rather than allowing the secondary TR to progress to torrential level, and then you do all palliative measures. So these are all palliative therapies, and we need to understand, and these are costly devices. So relevance in our practice is little doubtful, but it's again a ray of hope that this clip which is successful in mitral level can also be used in tricuspid valve, although the numbers of patients were very less than 100. So it still has to long way. It's still a long way to go. But this is a good trial which has shown some efficacy only on functional improvement front, not on survival or any sound reduction in cardiovascular or total mortality or even heart failure hospitalization.
Great. Raghu, your comments on
I
the triluminate?
I think whatever you had been telling about the trick valve as well as as Dilip has pointed out, these are all, they remain to be a palliative measures in the therapy. I think that's what I think. I'm not sure whether I can recruit a next patient for these therapies, because it's quite tough in my practice to find another patient for these things.
Yeah. So, Pranit, your comments. We all understand the challenges between, is it too early or is it too late, and the RV is already fired, and are we, and the core time course of futility. So defining the natural history is truly a big judgmental issue. But there, I think that doing an edge-to-edge repair kind of gives you a little moral advantage over actually doing either a prosthetic valve or even using a cable solution. But your comments, Pranit.
Yeah, theoretically, it works by reducing the tricuspid regurgitation. It should definitely improve the quality of life. But we understand, if you can, I know it's not a right comparison, but if you compare with TAVI, if you can replace a valve versus repairing a valve, it would always be better. I wish both in mitral space and in tricuspid space we get devices where we can replace the valve and we can restore the anatomy, we improve the both RV remodeling. I think that will be a long way to go. But I think definitely we are in the baby steps forward. We are improving their quality of life, which is equally bothering the patient. Hopefully, we improve device structure and we can equally improve their mortality as well. I think we are in the right track. I think in the days ahead, we'll be getting better devices.
Great. So it's like I also have a challenge in recruiting these patients because sometimes it's too early and sometimes it's just too late. So that is, to my mind, the biggest handicap. We all know the sick patient when we see one, but most of the time we are just hoping for palliation. And of course, even improving quality of life is very, very important. It should not be, the value should not be underscored for a guy who comes with recurrent ascites and who's miserable. If he improves, and even with a trick valve, there is some benefit that even it comes on RV function. It's difficult to understand how, but yes, maybe it is the RVPA coupling, but all the same, I think this is an exciting field. So we go over to the next, which is actually this is the trial of transcatheter valve repair and heart failure with moderate to severe MR, and we all know that this is the Reshape Heart Failure 2 trial, which now we are not looking only at severe MR, but also with moderate being included. This is to whether an edge-to-edge repair with OMT or just an OMT alone would be important. It was testing the mitral clip in the third population. So really, because we all know that from the different results we had in the COAPT and the MITRA FR trial, the Reshape Heart Failure 2 was actually quite important. The age was around similar, around 70. EGFR was about 56. The NT-pro BNP with mean of about 4,000, median of nearly 23,000, ejection fraction around 31%, mean regurgitated area was about 0.23, and the 6-minute walk distance was about 300 meters. So these were sick patients. And what happened when we gave them device plus guideline-directed medical treatment versus the control, which had only guideline-directed medical treatment? And we find that at all points, the NYHF classification functional class was better, including cardiovascular hospitalization for any cause. And a key takeaway is definitely that the mitral clip on a background of maximally tolerated GDMT was superior to GDMT alone in reducing heart failure hospitalization and mortality in 2 years in symptomatic heart failure patients with grade even up to moderate mitral regurgitation. So having said that, let's have this out for discussion. Maybe Dilip can take the lead here and tell us how he looks at it. How does he define? So if you have a functional MR and you have a moderate functional MR and the patient is symptomatic, do you still think you would include? And we all know the challenges in assessment. Even the echo assessment can be very challenging because the higher the LA pressure, the less several echo criteria would apply in determining how severe the mitral regurgitation is. And we know the differences between COAPT and MITRA FR were whether it was appropriate or inappropriate mitral regurgitation. But over to you, Dr. Dilip,
Yeah.
for your
Sir,
comment.
actually, this was a long-awaited trial. It came after 6 years of gap. So COAPT and NITRA was, the trials were presented 6 years prior, and it came after 6 years, and it was considered to be a tiebreaker because there was a tie, MITRA-FR and COAPT, they had opposite results. And in fact, it showed that the kind of results are going in favor of COAPT because there were little less sicker patients than COAPT, but still it showed a positive result. But there are one or two, again, there are 2, 3 points which we should look at, especially from Indian, perspective. There are 250 patients were there in each arm, medical optimized OMT arm versus the TER arm. And at 3.6 years, half of the patients were dead in both the arms. And eventually, after 5 years, if you go with the kind of natural course of these patients, with or without clip, all the patients will be dead. So if we are doing these patients, even if they are COAPT group of patients, 20 to 50% ejection fraction with a very, very significant, mitral leak with a kind of mitral valve orifice area and the resultant leak effective orifice area would be more than kind of a 0.4, even then the survival benefit is not there. But again, I think I really am really impressed with Dr. Praneeth's concept and idea that these are not the permanent solutions. These clips, whether it is at mitral level, which is a tricuspid level, They are just a palliative therapy unless we come up with a solution like tower, like a TMVR with an intrapid valve, which is going to be a little more exciting. And the same as the tricuspid valve with another valve from another valve which is coming up. So these valves will be game changer. This clip business which is happening and being given in most of the patients, the durability and at 3 years, 5 years results are real doubtful. And for Indian perspective, I don't think they are a solution which we should look at very aggressively at this moment.
So the heart failure per se and functional MR is, or functional TR for that matter, is as it is a very depressing kind of scenario. And despite the great advances in heart failure management by the GDMT for heart failure, by a variety of different options, we still have people who suffer a lot because of chronic heart failure. And there, even an improvement in quality of life, not so much in quantity of life, would be beneficial. So, Pranit, your views on this, and then we'll have Dr. Raghu's views on this.
Yeah, so most of my statement would be with the previous talk as well, previous trial as well. I believe these are more of palliative, but because we don't have anything at this point of time, I think it is better something rather than nothing. We don't want people to suffer, so at least offer them those who can afford. But it's definitely you feel bad when these patients come back after 3 years with a repeat MR, and now you have to tell them that you need another clip. You only feel guilty that you cannot offer them again. So I think cost definitely makes it very unaffordable for Indian patients when they do come back with a repeat mitral regurgitation. Other than that, I think at least for few who can afford, it definitely helps them not suffer that much.
And Dr. Raghu?
Yeah, my take will be a little different from my colleagues. The first thing is we have to differentiate whenever there is a mitral regurgitation. We need to assess the patient. What is the reason for the mitral regurgitation? That is the very predominant thing which I think needs a shift in the practice in our echocardiography, whether it's a primary mitral regurgitation or a secondary mitral regurgitation. Once we have labeled it as a secondary mitral regurgitation, systematically I think taking this data into account, we need to start identifying the patient who will be benefited, like the natural history, what you are alluding to. We need to understand whether what is the reason for the MR. Is it due to atrial myopathy, or is it due to angular problem, or is it a ventricular problem? People who are having a ventricular problem where the cardiomyopathy is the main reason, the muscle is the main problem. I think the clip treating the valve might not be a solution. But whenever there is a primary mitral regurgitation, which is not uncommon, you have got an 80-year-old male with a mitral valve prolapse, quite common. Those individuals are quite high risk for these mitral clip procedures, and where we can do. And earlier the better, not wait late till your patient gets sick. That is the reason why you had the benefit in the reshape HF2 and the COAP trial. So choosing the right patient is the key. Then finally, I would like to mention that the procedure of mitral clip is a pretty safe procedure, and the event rates are much lower compared to even a TAVR also. So it's quite a very controlled procedure under nice echocardiographic guidance when we do this. So I think we should be able to benefit a good number of patients. But the most important thing is we should catch them before the onset of significant left ventricular dysfunction. So you should treat them early rather than treat them late. That's my take. The reshape HF2 also reaffirms that point.
So one
Great.
point here, yes, one point here. See, the COAPT had a very low NNT. The number needed to treat was very less. And this trial, the Reshape Heart Failure 2 trial, result is nowhere closer to COAPT. Although it gives a little hint and shows us some hospitalization benefit. Again, there was no cardiovascular mortality benefit. The kind of benefit which we saw in COAPT was nowhere, which we could see in Reshape Heart Failure 2. So which way we should consider the result of this trial is difficult to understand.
I think
Whether
it's about inclusion criteria. It's also
Yeah.
about the
these
operative
were
experience.
these the reshape heart failure true were mostly in line with co-op trial. So the recruited patients were
So
very
it's
close to
also about the
co-op,
operator
little
experience, center experience.
Yeah.
And I think we need to be a little more judicious in defining the mitral regurgitation. I completely concur with what Raghu said. Mitral regurgitation is not one disease. It is sometimes very, very challenging to find whether this is, and a lot of them have atrial fibrillation. So whether it is an atrial functional mitral regurgitation, is it a ventricular mitral regurgitation, what is causing it? So we need to define very precise echo or even MR criteria to be able to actually define which patient is likely to benefit with this therapy. So I think there's a lot of work in progress. We all have had anecdotal cases which have had dramatic improvements where peer pressures have come down, patients have started, and it all started apparently with Elizabeth Taylor. But notwithstanding, I think in heart failure with functional mitral regurgitation, we need to develop appropriate criteria. And till such time, we will win some, may not win some more. TMVR is not yet there. It's a complex valve. We
Yes.
understand it's a saddle on a horseback. It's kind of difficult. We are even understanding mitral valve prolapse much better now with more understanding about the mitral annular disjunction syndrome and its various ramifications. So I think our understanding as we go in depth and try to generalize every mitral regurgitation, throw it into one basket, is going to be inappropriate. We need to work on this more and get the appropriate natural histories. So I think we have finished 1 hour, and
Yes.
so if it is okay with everybody, we can do the part two maybe next time, because we can cover because we still have 5 more trials to go, which we had planned today, and I don't want to lose everybody's interest. I think we've generated a fair amount of disruptive thought process. What do you say, Dilip?
Correct, sir. I think we can discuss the remaining studies
Another day.
next time. Yes.
Yeah. So if it is okay with Pranit, it's okay with Dr. Raghu. Raghu is okay
Yeah,
with
yeah.
you, then I
Yes,
think
yes, yes. I
Yeah, I
think
think we can little discuss more on this mitra clip and tri-clip, and the
Yeah.
kind of valves which is coming from Pascal for tricuspid. That Tricent 2 trial has come. Which
Tyson
is-
2 is here.
yeah, so which is really showing promise. So the final verdict will be through the valves, what I feel, and this is my kind of conviction.
The landscape of devices is grown so exponentially, and we all know that it does not matter. It does not mean that even if you provide small iterations, and the case in point is the recent thing with the tower device for say from Boston Scientific. Everything that we try to do that we will be able to improve this, that, and the other does not always generously impact outcomes, because we probably need to identify the subsets which are going to be maximally benefit with a particular iteration of the valve, a particular iteration of the therapy. So I think that is what is most important for the pundits in the group to actually identify a good and more precise choice points so that we can choose appropriate therapies.
Yeah. And the
Yeah.
best part with clips is these are very safe to be performed, and very safe to perform, very less kind of side effects when we go for a mitral clip device. But the end, if the ventricle is at fault, this clip is really not an answer. I think Dr. Raghu was very right, rightly pointed out that atrial, MR, these patients, if we choose correctly, like primary MR sometimes can be of, huge help with this clip devices.
Great. So with that, I think we will close the new year, the first session, and wish everybody all good wishes for the Uttarayan and Makar Sankranti and so on and so forth. And I thank Dr. Pranit, Dr. Raghu, and Dr. Dilip, and we also obviously thank Ajanta and their team for their invaluable support to conducting these programs. I do hope that they're of benefit to others. They do benefit us, at least for myself. I can speak that they benefit
Yes.
me. All right. So with that, I'll hand it over back to Anand And
Yep.
if you'd like to say a few words,
Yeah,
and then
sure,
maybe we
sure,
can
sir.
do the rest the next.
Sure, sir. So once again, thank you so much, all the panelists and moderator, Dr. Dilip Kumar, sir, Dr. Pranit Polamuri, sir, and Dr. C. Raghu, sir, and of course, moderated by Dr. Anil Dal, sir. Thank you so much. As